Hello, everybody. Welcome. We'll get started in just a moment. Hello, and welcome to UCSF Community Connections on Health Equity. We'll get started in just a moment. Hello, everyone. Welcome. We'll get started in just a moment here. Okay. When we get started. So welcome, everyone, to UCSF Community Connections on Health Equity. I'm Allie Jones. I work in the Office of Community and Government Relations and wanted to just kick us off with a few housekeeping items. If you feel comfortable, if you could please consider putting on your video to create a more in-person feel, that would be wonderful, as this is the most in-person we can get these days in these large events. We will be recording this event and we'll make the recording available after today's discussion that you feel free to share. And please, as questions do come up, feel free to submit them directly into the chat to me. My name is UCSF Facilitator Allie Jones, and we'll save a good portion at the end of today's panel discussion for Q&A from our participants. So I think with that, I'll kick it on over to Vice Chancellor Vega, Francesca Vega with UCSF Community and Government Relations for some opening remarks and introductions. Stop sharing, and here we go.
Thank you, Allie. I want to recognize Allie Jones and the team from Ground Floor Public Affairs for their coordination in making today happen. So thank you so much, and thank you to all of you for joining our second Community Connections event. Community Connections is an ongoing series that focuses on UCSF's impact on San Francisco and the Greater Bay Area. We created this series in partnership with Ground Floor to provide an opportunity to engage not only UCSF, but city and community leaders in partnership around issues that impact all of us, that affect our community, that are top of mind. What we've experienced over the last 2+ years has heightened awareness around existing health equities in our community, disparities that have only continued to increase and be more urgent and top of mind. And I felt that the team felt that it would make sense, it would be timely to bring together a group of leaders where health equity is where they focus their efforts to discuss how we move the needle, how we take advantage of the discussion that is happening around health inequities. Now's the time to make lasting changes to our healthcare and public health system. Now's the time to invest in communities who have been disproportionately impacted by COVID-19 and have been historically marginalized from our healthcare system. So we've convened today's conversation to hear the perspectives of these experts, which I'll get to in just a moment. Each of the women that are joining us today have a different role to play when it comes to health inequity. So in the hour that we have, we will try to dive in and touch on the expertise and the feedback, the recommendations from each of these four leaders. What I will do is I'm going to go through each of the panelists that are joining us, and then I will ask each of them to just take a quick minute to share with all of us the work that they're doing in this space. First, we have Dr. Ayanna Bennett, Chief Health Equity Officer with San Francisco Department of Public Health. Dr. Bennett.
Hi, everyone. My role in the health department is new in title, but not so much in function. The Office of Health Equity that I lead is attempting to move both the clinical services and others into active opposition to the health disparities that we have, including the disparities among our staff in terms of their treatment, their advancement. So that is a lot of job because we have a lot of diverse areas, but there are ways to improve everywhere.
Thank you, Dr. Bennett. Thank you again for joining us today. Dr. Vitka Eisen, CEO of Healthright 360, has also joined us. Dr. Eisen.
Hi, everybody. Thanks for having me here. I lead Healthright 360, which is a nonprofit organization some of you may know as Haight-Ashbury Free Clinics. And our work has always been focused on providing healthcare services, including substance use treatment, mental health services, and primary care to low-income people and people experiencing homelessness in San Francisco, in which case that population is largely, people of color are largely represented in that population. And so that is where the kind of the focus of our mission and our work. And as a part of that, we also see advocacy work around social policy that impacts communities of color and the people we serve. We're very actively engaged, not in just providing care, but in advocacy as well.
Great, thank you. Dr. Kirsten Bibbins-Domingo, UCSF Dean for Population Health and Health Equity, and a great partner to the Office of Community and Government Relations. Dr. Bibbins-Domingo.
Hi, thank you for convening us all here today. So I'm Kirsten Bibbins-Domingo. I'm the Vice Dean for Population Health and Health Equity in the UCSF School of Medicine. I'm also a general internist and a researcher in heart disease, and I practice at San Francisco General Hospital. This position, I was appointed 4 years ago, and it's a new position at UCSF, not because health equity is new to the School of Medicine or UCSF or the faculty or the students and the work that we do, but that it was to sort of underscore its priority at UCSF and to think about how to create the infrastructure and the investments that could allow us to do our scholarship in a better way in health equity, how to link the scholarship that we do to the care that we provide at our hospital and clinical settings, and then how to really think about what isn't needed to, in fact, move the needle, as they say, in the issues related to health equity in our communities and where we all live and work. And so it's been a very interesting journey, and it's especially, I think, exciting to do this work because so many people are committed to, and so being involved in how to think about doing this better with more impact has been, I think, the bulk of this work over time.
Thank you, Dr. Bibbins-Domingo. And lastly, Wylie Liu, UCSF Executive Director of the Center for Community Engagement and our fearless leader of the Anchor Institution Initiative. Wylie.
Thank you so much, Vice Chancellor Vega. I'm so pleased to be here and to serve on this panel with such amazing, distinguished women and leaders in the field. So I'm Wylie Liu. I am the Executive Director of the Center for Community Engagement. My role is really to create an infrastructure for our institution to partner more in meaningful ways with our community partners and stakeholders, be it through research or education or healthcare, More recently, I've been spending a lot of my time working super upstream, really looking at the business practices of our institution and how to leverage that to advance health. And I'm happy to share more about that later. Thank you.
Thank you. And again, thank you to the four leaders that have joined us today. As part of UCSF's community benefit role, UCSF and all the health systems in San Francisco conduct a community health needs assessment every 3 years. We do this in collaboration with the San Francisco Health Improvement Partnership. In the last community health needs assessment, we identified the following priority health needs: access to healthcare, food security, housing security, safety from violence and trauma, social, emotional, and behavioral health. The San Francisco Improvement Partnership also highlighted 2 foundational issues contributing to health: racial health inequities and poverty. No surprises here. We are in the midst of another community health needs assessment. Preliminary data suggests the priority health needs and inequities identified last time have been exacerbated by the pandemic. Again, no surprise, unfortunately. Worsening mental health outcomes, housing insecurity, food insecurity, and economic downturn. So today, we are here to learn more about these disparities and explore, again, best practices, how we can come together collectively, as well as continue the work as individual organizations to turn these issues on their head. I'm going to start with questions. This first question is for Dr. Ayanna Bennett. As the city's health equity officer, what trends is the city seeing when it comes to health equity and disparities within our communities? How have community health strategies shifted during the pandemic?
Well, the first thing that shifted during the pandemic, I would say, is the quality of our information. It's not great. So if we had a pulse on where people were before, and that wasn't perfect, but people came in, you knew what their blood pressure was, you had a sense of just how under control or not under control people were for various chronic diseases. I don't feel confident that we have that at all now. Many people became quite disconnected from the system when the system disconnected from them, and they didn't necessarily come back when we decided they should. And some of the progress that we had made was in being more connected and more aware of the people, at least that we were taking care of. And I think that was true for other systems. And so across the board, I'm not sure that will be recaptured, but it certainly didn't persist throughout the pandemic, that people had the same quality of contact that they had before. Much of what's wrong in health equity is poor quality care. We don't like that one. We like it to be that there's something either wrong in the community, which is true. There are lots of things that we've done in the community, but there are also things that we do. So some of it is us, and I think that awareness that we were pretty close to getting to and trying to really work on quality improvement and really work on everything down to the way people get treated by security. All of those things pretty much got frozen in amber for a little bit, and I'm trying to restart all of those engines and with fewer people, because both people are still doing COVID. Every other department in the city has gone back to their normal jobs. DPH is still doing quite a lot of COVID. And it doesn't feel like we've completely recovered to where we were. So in terms of what the trends were before that, there were many ways in which things were better on some aspects, especially if you look over a long period of time. Debate over what the reason for that was, but nationally and somewhat duplicated locally, improvements in heart health and life expectancy. I think we've probably lost most, if not all of that. They've lost all of it and more. In some parts of the country, we're doing a little better, but all of those things were slow to be produced. So some of them maybe were accessed with Obamacare. Some of them were different access issues in California that were a little bit better than they were in other places, but all of them were dependent on a kind of stable functioning system. And I think we ceased to have that for a while. So things were getting a little bit better in some bright spots. I don't know that we retain those. I'm going to guess we didn't. And other areas did what the whole picture has done, which is remain remarkably, horribly stable for decade after decade after decade. So the fact that when we did the first geo-mapping of where all our COVID cases were, and it looked exactly like our redlining map, it was very unsurprising because our asthma looks like our redlining map, our heart disease looks like our redlining map, our school quality looks like our redlining map. We have still geographically distributed every resource and negative based on the segregation that we achieved early in the century. So we are, and until we deliberately undo some of those things, they're not just going to get better with, I don't know, personal ingenuity, or I'm not sure what we think the thing is that's going to make it better, how the government can create something that then I guess just through innovation, people are supposed to fix on their own. They're not, they can't, and we haven't deliberately tried to do much about it yet. So we're just going to keep seeing that both geographic and racial pattern in everything until we do something about it. So stability with a few bright spots, and I don't know that we've kept the bright spots.
Well, I appreciate you touching on, and we discussed this as a team in planning this this discussion today. We discussed how broad the issue of health inequity is, or health equity is, and you touched on, security. So security in hospitals, how people are treated from the moment they arrive is such an important piece. We've been having those discussions, and Wylie's been a part of those discussions internally at UCSF. I know that just on some of the points you touched on, we could spend an hour just talking through each aspect of health inequity that is not on top of mind for most folks. So thank you for your honesty. Next question is for Dr. Kirsten Bibbins-Domingo. How is UCSF tracking equity in San Francisco and beyond? And what role can UCSF play in addressing these inequities?
Yeah, thanks. I think that UCSF has many the core of many of our faculty, either as practitioners, as researchers, as teachers, is devoted to health equity and to understanding this and speaking about it on a national level, both the trends as Dr. Bennett has described, as well as the potential at least pathways to trying to both reverse disparities that we see and to put us on a path towards achieving health equity. I think our biggest challenge is figuring out how to translate all of the work that we do into actual improvements in health and health equity, and that's where we all want to be. We want to move away from the descriptions, which we know, and as Dr. Bennett suggests, have been there forever, to actually understand using what we know about the sources of those inequities to actually improvements in health. And I guess I would underscore three things in the way I think about the pandemic that both lead us to understand what we have to do to start to get there, but also highlight the challenges. And so, when the pandemic first hit, a question was, well, what is the role of UCSF? Our role is providing care. We're not, and so that certainly was what we did, leading and driving innovation. innovation, which of course is also an area we worked in. We're not a Department of Public Health. But one of the things that is true about health equity is that those patterns that we see between the east and west side of the city, between different demographic groups within the city in the experience of the pandemic, while they might have been completely expected, the solutions to reversing them require many different types of stakeholders to work together to achieve a different goal, right? So the first thing that I would say is that health equity work is by its nature multi-sectorial, by its nature requires collaboration, requires partnerships, requires coalition. And I think the most effective work that UCSF has done through the pandemic has been to work as a part of a coalition to bring the expertise that we can bring, which oftentimes sits in these areas of data or demonstration projects or evaluation, to the work, but recognizing that we are not the leaders here, we are partners with others who bring their own expertise to try to bring about change. So the first is the requirements for collaborations, partnership. The second is just recognizing that the very nature of health inequities is that it is at its core about power and privilege, or the lack of power and privilege, and that these coalitions that to work effectively have to, in fact, challenge and understand that this will be disruptive to oftentimes systems of power and privilege, right? And that is in fact hard work to do, right? We got here because these structures have existed for a long time. To work in a way that works in opposition to those structures, and recognizing that, I think is hard work. And I think one of the things that happened during the pandemic is that just the sheer urgency to address the issues got people to think differently for periods of time, to think a little bit outside the box, a little bit in the way we normally don't act, and I think to good effect. But the last thing that I would say is that, just like we didn't get here overnight, this is going to require sustained investment. This is going to require more than just, recovery from the pandemic. It will require thinking through the many things that got us there, and thinking in deliberate, sustained ways over time. And I think for me, this is sort of it's a crucial point right now, is to figure out how we build on the partnerships that I think we have developed and sustained, the different ways of thinking, but to think about that in a more sustained way, because that's what will ultimately be required.
Definitely. And I know that you and I have talked about this, but I couldn't agree with you more on how do we ensure that the coalitions and the partnership collaborations are sustained? How can we take advantage of this moment and find a grim silver lining? Thank you, Dr. Bibbins-Domingo. This next question is for Dr. Vitka Eisen. As I mentioned before in my earlier remarks, the Community Health Needs Assessment highlights mental and behavioral health as some of the greatest challenges facing marginalized communities. Does this align with what you're tracking on the ground? Can you talk about the challenges facing the people that you serve at Healthright 360? What do you see as the greatest areas of opportunity in what the behavioral health delivery system can offer patients to promote their health and well-being? And if you don't mind, just continuing off what Dr. Bibbins-Domingo shared, if you could touch on some of the partnerships that have emerged during the last couple years, that would be helpful for all of us. Thank you, Dr. Eisen.
Sure thing. So I'm going to really focus, although I talked at the beginning about all the kinds of work that Healthright 360 does, I'm really going to focus on our behavioral health work, and in particular, our substance use disorder treatment, as well as mental health services. Because Healthright 360 is the largest provider of substance use disorder treatment for low-income and low-income people and people experiencing homelessness in San Francisco. So we have a good idea of the impact of health disparities and inequities on communities of color based on the work that we do. And I'm going to start with just talking about kind of let's say the elephant in the room, which is overdose deaths and overdose statistics. I think people are probably aware that in 2020, we saw the largest increase in overdose deaths. We had the largest number of overdose deaths across the country. Over 100,000 people died from drug overdoses in that period from May of 2020 to April of 2021. And in that similar period in 2020 in San Francisco, we had 711 deaths from overdoses. And that's more people in San Francisco who died from a drug overdose than people who died from COVID. So it's this quiet crisis that kind of loomed behind COVID, and in part because so much of those deaths were focused very, very specifically on disproportionately Black and brown people. In terms of the where we're trending right now in overdose deaths in San Francisco, there have been 545 deaths from January 1st to October 31st of this year. So it's been a really rough time. And some of that is driven by COVID, but a lot of it is driven and by isolation and people using drugs in isolation, not being able to be, in community with people when they're using drugs. But of course, some of it's driven obviously by a toxic drug supply. And by that, I mean drugs with fentanyl analogs contributing to a considerable amount of drug overdose deaths. When you look in the San Francisco Department of Public Health report, Phil Coffin's report on drug user data in San Francisco, African Americans in San Francisco in 2019 were 4 times more likely to die of a drug overdose than white drug users and Latinx drug users. And older Black men had a disproportionately higher overdose death rate than any other group by a very significant margin. And despite the overdose death rate, even though African Americans are admitted to substance use treatment at a higher rate, there's a significant drop-off in the movement from entering into detox and then moving into a continued level of care. So there's lots of challenges and lots of opportunities for improvement and lots of work that needs to be done. The numbers for overdose deaths in 2021 are looking very similar, including proportions, and most of those overdose deaths have occurred in the Tenderloin and Soma community. So like, what causes this outside of the toxic drug supply? And I would say that the criminalization of drug use has had a disproportionate and negative impact on Black and brown communities. And I believe that this was the intent of the policies. When you criminalize what is drug use, it has driven the mass incarceration of Black and brown communities, which has had massive health effects for generations, for a number of generations on communities. It not only drives shame and stigma, it's a failed policy. It blew up the prison system. People came out of that much sicker. And so those policies are failed policies. And I would say I'm concerned in the current moment that there is a consideration of returning to those policies. And so I think when you're facing a crisis, it's an opportunity to do things incredibly and completely different. And COVID actually forced some things to be done differently. So when during COVID, when the SIP hotels were created, the shelter-in-place hotels, and the isolation and quarantine hotels were created, we found ways to let people continue to drink and to use drugs. We introduced, the county introduced, in fact, what were de facto managed alcohol programs, which help people actually drink less because they're not drinking out of a place of scarcity. We were able to more observe people who were using drugs, if you will, because if you're in a isolation and quarantine hotel, we're going to make sure that people aren't going to die of an overdose. So it gives us an opportunity to think about things and do things in a very different way. But it also obviously, presented some huge challenges. For one thing, it throttled our intakes. We had to make space and treatment for quarantine space, reduce the number of people that we could take in. So I think There were also a number of partnerships that we established, I think, before COVID, particularly with UCSF and with San Francisco General, to try to place intake teams in emergency departments. So we would facilitate the linkage to care. I think some of those things were interrupted, obviously, by some of the challenges of COVID. So like I said, you know, when you're facing a crisis, both COVID and the overdose crisis, it is an opportunity to do some new things. And what do those new things look like? So some of those things have to do with the drug. We're working with the Department of Public Health on opening what's referred to as a sobering center, but it's actually, we refer to it as a drug crisis center. This is a place where people can be who are, you know, activated, dysregulated out on the streets, having used drugs. They can come in, be observed, and connect. We can connect with them, see that they make sure that nobody dies of an overdose. We can make sure that they can be connected to care, get some food, take a shower. We're also working. The Department of Public Health has started the Street Crisis Response Team, which is a way of, it's an alternative to policing, which is a way of responding to people in mental health crisis on the streets. So you call 911, instead of the police department responding, then you have paramedic, mental health clinician, a peer support service. And in this way, you're less likely to have a negative police interaction with people living on the streets. And then at the other two final things I think I want to mention in terms of health equity, preventing people from dying, have to do with consideration of opening supervised drug consumption spaces. These are spaces where people could come and bring pre-obtained drugs and be observed while using them, but also be connected to care. We make sure that people don't die and have connections to care. And finally, safe supply. If you have a toxic drug supply, which is what fentanyl analogs are, then we need to replace them with a supply of drugs that includes methadone, that includes buprenorphine, but it also includes other kinds of opioids that we can manage in such a way, make sure that people don't die of them. The final thing I want to say is that our organization largely employs people with lived experience. A very high number of people with lived experience who work in the organization, a high number of staff members who are people of color. And there is so much pay inequities for the people who work in the nonprofit sector that is incredibly challenging to hire and take care of the people who take care of the people on the streets. And we cannot provide the kind of services that we provide if we don't take care of the workers, who are largely people with lived experience and people of color. So I think this is an opportunity. This is a workforce crisis. All of the health departments and health service organizations are experiencing this, but this is an opportunity to really take this on as a challenge. Thanks.
Thank you, Dr. Eisen. I appreciate that, that you're kind of unique, the space that you work in, sharing with us, you know, what the last couple of years have looked like. I want to wrap up, and then I have another question for all of you, but I'll wrap up with Wylie Liu. And Wylie is San Francisco's second largest employer, which, you know, that's a talking point that that myself and many of my colleagues are always quick to share. And of course, that comes with so much responsibility. That comes with so many ways that we can collaborate, that we can leverage UCSF's the power, our economic power, and of course our talent. How can UCSF promote health equity through workforce development, procurement, and community investment, three of the pillars of the Anchor Institution Initiative, of course, and address economic disparities as a barrier to health and well-being?
Thank you so much, Francesca, for that. I want to maybe start with what you began, which is framing this discussion around what we see as needs in the community. And I want to quickly acknowledge Michonne Coleman from the Hospital Council. So Hospital Council has been co-leading with many hospitals in town in doing the community health needs assessment as part of our nonprofit hospital regulatory requirement. And 2.5 years ago, when we did this, we, for the very first time, emphasize the fact that some of the foundational causes of the health inequities and disparities we see are poverty, lack of economic opportunity, and institutional racism. We're pretty close in finalizing our most recent 3-year needs assessment, and those issues have come up again and again. So one of the ways that UCSF is looking at addressing these foundational causes is through this anchor institution framework. So I want to maybe go back a few years, maybe 5, 6, 7 years ago. Many of the nonprofit hospitals like UCSF have decided that we're all do tremendous community benefit work, but we can really augment that by leveraging our economic power to advance health. And by that, I mean just what Francesca just noted, the way we hire people, the way we make our purchases, and the way we invest our dollars, and looking at the policies and practices around that. So UCSF joined this growing sort of anchor movement to do just that through our anchor institution initiative. On the workforce front, what the strategy we have deployed that is what we call outside in and inside up. So traditionally, a lot of institutions are pretty good at hiring people from our diverse community into entry-level positions. We're doing that, many of you are doing that, but we have not done a good job of thinking about creating pipeline from these entry positions to mid-level positions. So we have Michael Jones now at UCSF really helping us look at how do you develop this pipeline, how do you grow those talents, because frankly, it is not cheap living in the San Francisco Bay Area. You all know that the Bay Area has the highest income inequality in California. So that's one piece. The other piece we're constantly reminded is do not forget about our young people. They are our future. So we have a pretty robust K-16 pipeline work that we're looking at right now, not just addressing STEM. I mean, we're definitely interested in STEM, but also non-STEM opportunities at UCSF, engaging young people, exposing them to our finance jobs and our facility jobs, etc. The other piece I want to mention is procurement purchasing. When we started doing this work, I learned that UCSF spent over $1 billion purchasing goods and services every year. That is a tremendous amount of money. So what we want to do is look at how can we increase our spend with local small businesses as a way to stimulate economic activity in our diverse communities. So that work is led by Marlise Capata. Marlise, I see you there. So very, very challenging work, but we're doing it. And then the last piece I want to quickly mention is our community investment piece. I'm not talking about grants here. I'm talking about investing in a social endeavor where we can have both a financial return as well as a social return on that investment. And we are super excited to embark on a pilot $5 million project where we're funding the San Francisco Housing Accelerator Fund, Asian Inc., Redif Investment Fund, as well as Pacific Community Ventures. This is a very diverse set of financial partnerships where we will be looking at housing, social enterprises, and business development. I want to just also quickly say that this is very hard work, as Dr. Bibbins-Domingo noted. It is very hard to do this because it's not performative. We're trying to change the culture, the system, the structure of our institution. And in order to do that, we have to have deep partnership with the community, with our community-based partners, as well as our public sector partners. And I'm so glad to see Dr. Bennett here. DPH is definitely a very strong partner. Office of Economic Workforce Development, Human Services Agency, and increasingly the Human Rights Commission is right there. And it's important that we partner with them because they guide us. This is not how we've operated before. So they're guiding us on how to do this. We're showing tremendous humility, and also they're keeping us accountable. We're making sure that we're doing what we're supposed to be doing. So those are a few things I'm going to share for now. Thank you.
Thank you, Wylie. I appreciate it. I have actually a follow-up question for you and for Dr. Bibbins-Domingo. if you could just share a little bit more, because I realize with a large organization like UCSF, we're always thinking about, ensuring that community voices are front and center, and how we're incorporating community voices into our efforts, specifically around clinical outcomes, and of course, access. So if you could just touch on how UCSF is planning to more aggressively lean into these opportunities with community voices. And then I would like to hear from Dr. Bibbins-Domingo as well on that.
So I'm happy to get started on this conversation. So Susan Pappas from UCSF Health has done a tremendous job of bringing together some 11, 12 patient family advisory groups. She has reached out to our office saying that these groups are tremendous, they're really helpful, but then they tend to skew more wealthy, older, more white patients. So, and so she feels like she's not hearing the voices she needs from a very diverse communities. So she has reached out to our office to collaborate on looking at developing a task force where we can really strengthen those voices from our community, not just from a patient perspective, as well as from a community perspective, because there are individuals out there, community members, who may want to become patients in UCSF and don't know how to do that. So I just want to say that, we recognize that there's work to be done, and we look forward to doing more of that. And this is under the auspice as well as of our Health Equity Council, which is a group that came together some 2-3 years ago. Dr. Bibbins-Domingo is a leader in that effort, really looking at the health equity in our UCSF health system.
Dr. Bibbins-Domingo, do you have anything to add?
Yeah, I just want to say that just underscore all of what Wylie is saying here, and the patient advisory boards are always critical to the work of clinical institutions like ours, ensuring that they are represent the diverse voices who we know have different experiences is actually critical, and I think that is the hard work that Wylie is describing. The fact that this all sits in as a part of the Health Equity Council at UCSF that was established probably 4 years ago now, which really represents a way to think about the many parts of our institution that have to come together to really focus our clinical care on the issues of equity in care, I think has really been incredibly strong and powerful. The fact that the people who usually think about patient experience, patient voice, are at the table speaks to the way in which people who are focused on equity are trying to make sure that in that part of our organization that's also there. Let me just say that I think we also have had really outstanding work over time in thinking about community voice in the research that we do. We don't want to do our research sort of in isolation. Some of our research is actually actively community engaged research. Some of it is research that is not in the community but is affected, but affects the community, whether it's new genetic research, new ways we collect data where the issues of data privacy are there. And so we've done a lot of work. Dr. Grumbach is here on the phone, has really led a lot of this work. And I think really thinking through both how community advisory boards are structured, that they're structured to give input on a range of types of ways in which we conduct research in a meaningful way, I think it has been important over time, and actually weighing in on in a way that actually helps all of us do our work better. I think the most gratifying thing when I have worked in some of the research or funding opportunities with the community advisory boards is how much having community and patient voice as a part of how we structure our science, our innovation, actually makes it better science and innovation, and also hopefully I think then allows us to achieve our goal that the end result will actually is more likely to have an input on better health and better care for everyone. So again, it's not easy work because you want to have input on a whole wide range of things that we do, but I think we have some good models, and I think some good outcomes that have gotten many more people invigorated by the idea that it's just you absolutely have to start with that and having community and patient voice at the table.
Thank you, Dr. Bibbins-Domingo. Dr. Eisen, to kind of in the same thinking around innovative ways that you're engaging community, you touched on those that are actually helping or providing the care for patients, have lived experience. Are there other innovative ideas, or if you had your druthers and unlimited resources, what kind of ways would you implement that, that external, the community voice, or in what ways would you look to improve health equity, again, if you had unlimited resources to work with?
Wow, unlimited resources. That would be awesome. I think we have to first stop doing bad things, okay? Because if you look at the data on, again, I'm going back to the overdose deaths. If you look at the impact on overdose deaths on Black and brown communities, it is so far phenomenally greater, disproportionate to the number of Black people who live in San Francisco, that it should have alarm bells going. We should be doing like anything possible to keep people from dying. And if we do all things possible to keep people from dying, that again, the people who are dying are so far disproportionately Black and brown people. So from an equity perspective, stop doing bad things, which means don't think that policing the problem is the answer. That is a failed policy. And so let's not go back and do the things we did. There's a lot of innovative ideas on the table about doing something different to engage people in care for using drugs. And I referenced some of them before: supervised drug consumption, safe supply, which means providing people with other alternative drugs that are not, that the provenance and potency of, in a supervised way, in a way that you can then link people to care and connect people to care. So unlimited resources, we have a system of care that includes from the lowest barrier of service for people on the streets that are just like touch points and connection, and we're going to keep people from dying, to high intensity care that then transitions to follow-up care and recovery housing, which we have all of those things. All of those things are possible and have been proven effective in other ways. And then just in terms of the other part of the equity perspective, that the people who are doing this work, who have been doing it all through COVID, like nonstop with masks and no PPE, we need to make sure that they are cared for and compensated in such a way that they can survive and live in the city that they work in, that they don't have to drive 2 hours each way because the only place they can afford to live is. So you just gave me all the resources in the world. We're going to pay these people better, right? Because it is not feasible. They have to work two jobs, and they commute from Tracy and Stockton. And so that's what we do with all the resources in the world.
Thank you, Dr. Eisen. And I have one more follow-up question with Dr. Bennett. Please note, we have not yet received questions in the chat. So I'm going to take this opportunity to do a deeper dive on some of what was touched on. Dr. Bennett, can you say more about racial disparities in public health outcomes that you mentioned, and what have been the greatest barriers for implementing solutions to address these disparities? Go ahead.
I would say the greatest barriers are, in many ways, our thinking. So the way we envision some of these problems prevents us from solving them. The most basic part of that is that racism answers all the questions you don't have the answer to. Like, if you don't know somebody, you can tell what they're like. If you don't know whether this is good or bad, they're Black people or not. Like, it just answers every question. It's a really easy and comfortable crutch, and we don't realize we're using it. So when people try to envision why the disparity exists, many people still do what we did for probably a couple hundred years, really, but at least the last many decades, which is assume that the problem exists somewhere within these people or their families. So it is the way they smoke or eat, or it's something like that. It's some kind of choice they made. It's whatever. It's something about them. And the other side is when it's not about Black and brown people, it's something about the environment and the world. So that perspective, which we're able to take, needs to be shared across for all people, that they're given that ability. And that's an entirely different set of solutions than how come you can't behave better. And we've been doing how come you can't behave better for a really long time. And it doesn't work, partly because that wasn't the problem. And the other is that we don't actually have any real estate in people's thoughts and feelings that we get to control and do things with. I keep trying to tell all my friends working in equity who get so discouraged, like, you really can't have thoughts and feelings be your endpoint, because one, you have no right to alter their thoughts and feelings. Who do you think you are? And two, you're gonna fail. Like, you're just gonna fail that, and unless they're your kid or maybe your parent, they don't owe you any of that. But we do need to change how people think and behave in the work that we see them doing. So that's a different thing. So when we are trying to figure out why a Black woman with cancer did not show up for her visit, do we assume that there's something about her that doesn't care about her health or something? There's something about her. Or do we assume that our structures have not allowed her to do the thing that she would, like all people, like to do? We wouldn't assume other people don't care about having cancer. So why would that bizarre leap of logic make sense on the other side? Almost always, if you can change the characters in the story you're telling, it sounds ridiculous. And I try to get people to do that. He ran towards the gun. Really? That sounds ridiculous. If it was anybody else, why are you letting yourself believe a story that sounds like it was made for TV? So we're really been struggling with that. And it's not just the ideas about race that I think frees us from trying to actually make real solutions. It's also our ideas about what public health is, about what medicine is. So I think of my job as in the middle, and that what I'm trying to do is look at the health system and bring the message that most of what needs to happen, and not the social determinants of health message, because that was something out there needs to change, which is different than we, in order to be effective, have to be working in all environments. So we have to have some skin in the game of whether people have enough food. If you sent them home after their heart failure episode without any concern about what they were going to eat or if they were going to eat, then you probably should have just known that they were going to come back. Now they won't pay us anymore if that happens. So maybe we're getting more interested in it, and that is really helpful. But the whole idea that your entire responsibility sits in front of you in this person, in the way they are in your office, no matter how much you have curiosity about their life, that life that you're talking about is not in a person. It exists in a larger world. And until we really can think that way and think of it as a system, that's our responsibility, that we as systems have partnerships in housing, that we as systems, not just that the doctor asked if you're home, if you don't have anywhere to live, but we as a system are thinking, now what do we do about the living conditions? So what do we do? Not reinventing the wheel, but having some investment in the wheel and what happens to it. And the other side on public health, I always think the paradigm of prevention has been in some ways burdensome for the idea of helping people in all communities. If you are preventing heart disease, you pretty much miss the boat on many Black and brown people over the age of 40. So I guess you're done with that community by the time they hit their mid 30s, and everybody else, you're going to keep going until they hit 55. So they're already sick. We already have a system that is preventing your prevention from working. So you have to have something that you're offering to people who are already sick. You have to be able to give those resources to people who are already on drugs. You have to give those resources to people who are already diabetic. So that idea that we are just kind of perfecting around the edges, and when it doesn't work out right, it's not our fault. And we tried to pull you out of the river, but you kept going. Well, then build a boat. You don't just get to stand on the shore and go, I tried to pull people out of the river and I couldn't do it. You still have to do something. And so that those kind of ways of thinking that I think frees people from being creative in ways they are in other parts of their thinking in life, I think has really been a barrier, and it's moving now, but it's been hard to get past. One of the ways I do that is I like to talk about responsibility as if it were total. So I always, about anchor institutions, I say, they're poor. Wow, it must be because we did not hire them. We have all the money and they don't, and we didn't give them any of it. That's why they're poor. That is partly true. If you're a huge employer, that is partly true. And the sociologic reality is that when there's distributive responsibility, if your piece gets too small, it gets to zero, and we don't do anything. So if you take your piece as if it were total, because your role is total, it's not everybody else's role too, but you do have a total role that is complete, then maybe you can do something. And I think that's true in quality of care. It's true in people's lack of resources to live their lives. It's true in a lot of ways. If we would take more responsibility, not guilt or burden. If you don't think they're inevitable, which racism tells you it's all inevitable, and you think it's changeable, then taking responsibility shouldn't be so scary, because it's not inevitably going to be a failure. You actually might be able to do something and improve things. And having that kind of optimistic worldview that things can change, and that you're allowed to think of it in different ways than we've been given so far, I think are really a core of how to really move everyone forward. That's my whole speech.
Thank you. I appreciated the speech. Preventing prevention. I'm going to remember that. There's a few, all of you, there was a few phrases that were used that I've been taking note of. I have a question that's actually came from the audience. The question was specific to UCSF, but I think we have just enough time for each of you to answer. How or in what ways can community-based organizations, I'll say, support or continue to support, because all of us have strong, relationships with CBOs, but how can community-based organizations help us reach the goals that have been presented today? What can CBOs do, or where are some opportunities for them to help us move the needle?
I can get started on that answer,
Please do.
Francesca. Thank you, Rick, for joining us and for asking that question. So I mentioned that we cannot do this work without community partners. So under the anchor institution work, we have a steering committee with a subcommittee focused on workforce, one focus on procurement, one focus on community investment. We welcome community partners to join us in that effort. If you're interested in that, please reach out to me. The other thing is, I mentioned earlier that we're interested in purchasing from local diverse vendors. And although Marlise is doing a great job trying to collect as many vendors as she knows, but we don't have a full list. So if you know of, groups out there that has lists of small vendors, diverse vendors that you'd like to share with us, that would be another way to collaborate. And then Dr. Bibbins-Domingo mentioned our research endeavor and having community members participate. If you're interested in serving as a community advisory board member in our research endeavor, that would be another great way to join us in our efforts.
Thank you, Wylie. Dr. Eisen.
There's so many amazing community-based organizations that are embedded in communities of color that are truly, the voice of and represent the communities they serve, that have created community-defined practices. And I think that for large, what I guess what you're referring to as anchor institutions, that is an amazing resource that needs community. It needs like public investment and large scale investment, because there's things that those organizations can do and services that they can provide that are deeply embedded and grew out of communities that larger institutions and organizations can't. So I think just never let that be lost or forgotten, and that investment needs to grow.
Thank you, Dr. Eisen. Dr. Bibbins-Domingo.
Yeah, I agree with everything that's been said. When I think about the models of care, the way clinical organizations think about, as Dr. Bennett said, those social determinants of health, of everything that happens out there, the models of care that will allow us to do that will be the partnerships with the community-based organizations that are involved in the whole range of ways in which the social environment, the social context in which people live affects their health. There are ways in which we make that linkage very formal through people who work in health, like community health workers who are oftentimes in those community-based organizations, or we make the partnerships strong for addressing particular types of health needs. And what I would like to see over time is that we strengthen and formalize those. We can't in a clinical setting address all of the things that are in the social context that affect health without the partnerships with the community-based organizations that will actually be doing that type of work. That involves different ways of thinking, different models of care, different ways of financing care, but ultimately it starts with just a recognition that there needs to be a partnership if we're going to achieve those health goals that we all have and the equity goals that we all have. It will not be UCSF doing it. It won't be the Department of Public Health doing it. It will actually be the community-based organizations who actually play a leading role in doing that, and we all have to think about the models that allow us to do this all together.
Thank you. And Dr. Bennett, last but not least.
So the department has huge responsibility and investment in community-based organizations. Many of them, a significant part of their work is doing things that the department has moved into their hands that would otherwise be in ours. And for the reason that Dr. Eisen gave, that their hands are better able to do it. They just are. That being the case, the pay differentials that we have, and they are just being spoken about in seriousness in the last very little while, really do have to reflect the value and not just the opportunity. Like, you have a chance to not pay someone, let's not take it. So if just because people don't have the power to force you to do something, they don't have a union that'll strike on their behalf, doesn't mean that you should take advantage of that weakness. One of the things I do think has been really exciting about COVID is communities that were already somewhat organized internally in terms of culture and taking care of each other have now become much more politically organized in terms of united voice. Mm-hmm. So speaking in one voice, and now I have an American Indian budget, I have a Latino budget, I have a Pacific Islander, but I have things on my desk from all kinds of groups saying this is what we need. It doesn't matter how well-meaning we are in terms of wanting to listen, having a couple of community members, having even whole groups of community, having a rich array, any of those things don't represent community in the same way. They're a different way. So we are responsible for the community of individuals, like each individual person we see is a form of community, them in families and organizations, but also them as districts and neighborhoods and racial groups and the ways in which they organize themselves. And those are the ones that actually have the power to push us. Individuals can contribute and they're helpful, but the united Native American groups from across the city actually can push us. And that's what's needed. People government and actually all large institutions have a very hard time giving themselves permission to make large changes. There's a lot of resistance to that internally. And so there has to be an outside game. So it doesn't matter how many accomplices and good, well-meaning people there are internally. If there isn't an external push, it's very hard to get past either internal resistance or political inertia, one or the other. So that they're able to do that much more now after COVID, because it was a stress test that like no other. And I'm just amazed at how well all of our communities passed that test. They really did. They did not fall apart and just go off. Like, I have spoken to so many groups because they're groups. Like they were maybe social groups before, but now they're groups that said, hey, come talk to us. Hey, we need this. And I think that's something that has to continue if we want to really make these changes. And I apologize for my puppy.
Thank you so much, Dr. Bennett. I just want to take a moment and acknowledge all of the expertise, the passion and commitment represented on this call. I think it's clear we could go on for a couple more hours, really breaking the issues, the challenges around health equity, health inequity. But we had an hour and we did pretty good. We're four minutes over. Thank you again. Our continued failure to fashion an effective response it's just cannot be on the table. So it really will take collaboration with organizations represented here today, or ongoing collaboration, as well as the strength of our community-based organizations, which is clear. This recording, today's discussion, will be on UCSF's website, and we'll make sure to share it with our partners represented here today. Thank you so much, everyone, for joining. Have a happy and safe holiday, and let's continue to work together. Onward. Thank you.